Medical journals today are currently saturated with bold findings declaring that artificial intelligence algorithms consistently outpace human doctors in diagnostic accuracy. Aggregated statistical baselines from diagnostic meta-analyses seem to support this, citing an 81% pooled accuracy for AI compared to 71% for general clinicians. However, a closer look at the methodology reveals a crisis. Fewer than 15% of these AI diagnostic studies contain enough detail to be independently reproduced. In a controlled lab using standardized datasets, AI models hit a 95% peak. But when moved into a live electronic health record environment, performance plummets by up to 35 points, struggling with hardware artifacts and missing clinical context. Accurate evaluation requires identifying the specific human skill levels where an algorithm actually provides an advantage. Fragmenting the data allows healthcare leaders to move past surface-level headlines and identify the specific operational areas where AI provides genuine clinical value. The human clinician's level of experience is the primary variable in determining AI's diagnostic efficacy. This chart displays diagnostic accuracy by expertise. Against general practitioners, AI holds the advantage at 81 versus 71%. Against trainees, the algorithm hits 95% compared to 82%, an odds ratio of 3.34, a massive statistical advantage. Consequently, AI serves as an unparalleled decision support safety net, providing a real-time feedback mechanism for medical students and trainees. But the comparison shifts entirely when we evaluate expert specialists and subspecialists. But at the highest tier of practice, human experts achieve 91% accuracy, slightly outpacing deep learning models at 86%. Human experts maintain this lead because static algorithmic patterns cannot yet substitute for clinical intuition in complex multi-system pathologies. While AI successfully raises the clinical floor for novices, it has not yet broken the performance ceiling set by expert clinicians. Replacing experts with diagnostic AI is a statistical fallacy. Its true utility lies in elevating the baseline of inexperienced providers. Beyond human experience, AI performance also fluctuates wildly based on the specific medical specialty. This scatterplot maps diagnostic advantage. Algorithms dominate the right side, excelling in visual pattern recognition. Radiology and dermatology sit in this AI advantage zone. Cardiology and neurology occupy the center, showing no statistically significant advantage for either side. While AI successfully identifies narrow ECG anomalies, it fails to dominate the broader, context-heavy diagnostic requirements of these specialties. Ophthalmology presents a distinct anomaly on the left side of our chart, where human retinal specialists consistently beat the algorithm. Human specialists outpace the machine with an odds ratio of 0.75. AI remains vulnerable to rare artifacts and compounding anomalies that fall outside its training data. AI's effectiveness is strictly bound by data modality. It excels at static image analysis, but degrades when forced to interpret compounded physiological context. Even with high lab accuracy, an algorithm cannot function with full clinical autonomy in a hospital environment. Healthcare leaders are instead adopting a framework of augmented intelligence, designed to enhance human judgment rather than automate it. Consider a 10-hour workday. Clinicians spend nearly half their time on administrative data entry. By deploying Ambient AI scribes to target this inefficiency, the administrative block compresses by 70%. This allows doctors to redirect energy toward complex patient care. This shift produces a clear reduction in clinician burnout, with AI-assisted workflows yielding a highly significant odds ratio of 1.77. Proactive compliance reviews provide an administrative safety net, improving job satisfaction and staff retention by reducing the cognitive load on providers. The highest return on investment is operational efficiency, an administrative force multiplier, reclaiming time for high-value clinical work. AI outperforms generalists in isolated, image-heavy tasks, making it an exceptional triage and screening tool. Integrating this technology safely requires a task allocation framework to separate algorithmic strengths from human imperatives. Machine-exclusive tasks include high-volume pattern recognition and the screening of massive genomic or imaging databases. Collaborative tasks use algorithms for clinical risk stratification while keeping the clinician central to chronic care pathways. Human-exclusive tasks must remain the sole responsibility of the clinician. This includes ethical trade-offs, clinical consultations, and final diagnostic approvals. Keeping the sovereign clinician in control of complex realities is a non-negotiable safeguard for the patient-doctor relationship. The integration of clinical AI creates an augmented safety net that strips away administrative bloat and elevates the generalist's diagnostic baseline. This ensures that expert physicians remain focused exclusively on high-stakes human care.